It can be caused by falling on the buttock, prolonged exercise, obesity, having a shorter or longer leg on one side, fractures, inflammation of joints, osteoarthritis, pregnancy, following low back surgery, and also drivers in car accidents slamming hard on their brakes. Stay tuned to learn more about this painful condition.
Welcome to Region Med 101 podcast with Dr. Yu. Learn about all things medicine, health, and wellness. We hope you enjoy listening. Please show your support by subscribing and follow our podcast.
Sacroiliac joint, short for SI pain. Sacro or sacrum is a triangular bone in the lower back formed by the fused vertebrae or backbone situated between the two iliac bone or ilium, which are the hip bones of the pelvis. For the remainder of this podcast, sacroiliac joint pain will be called SI joint pain. Anatomy-wise, the SI joint has nerves that innervate the area, and this too is very complex, including dorsal rami, ventral rami, dorsal root ganglia, and even spinal nerve involvement. Unfortunately, evidence and research haven't pinpointed the exact nerves that innervate this area, but most professionals believe nerves from L2 to S3 are the main nerves. I would like to now introduce our special guest speaker, Dr. Ashley Wong, Chief Resident Graduate of Case Western University and current Pain Fellow at Montefiore, to help discuss SI joint pain.
Thank you, Dr. Yu Chu and Regen Med 101 for inviting me back for another episode. What exactly is the function of the SI joint? The SI joint is a diarthroidal joint, meaning there is a layer of cartilage that lines the opposing bony surfaces, and there's usually a lubricating fluid within the synovial cavity. The SI joints help provide us with stability when we are walking and act as shock absorbers during movement. The sacroiliac joint connects the hip bones, called the ilium, to the base of the spine, called the sacrum. There are many ligaments and muscles that cross the SI joint, which can also be affected. The main muscles that overlie the sacrum are the gluteal muscles, the iliacus, and the piriformis. Trigger points or spasms may occur along these muscles as a result of SI joint pathology. SI joint pain arises from injury, arthritis, or abnormal movement in the sacroiliac joints of the lower spine. Dysfunction or arthritis in these joints can commonly cause low back or buttocks pain. It is estimated that 20 to 30% of people with low back pain have a component of SI joint pain. Pain from the SI joint can be due to degenerative changes or osteoarthritis, traumatic events such as motor vehicle accidents or falls, excessive joint stress during exercise or work-related tasks, as well as sports injuries. SI joint pain is also common during pregnancy when the ligaments around the joint become lax and there's an increase in lumbar lordosis, or when the lower spine is more curved. This places more pressure on the SI joints. Inflammation of the SI joint from autoimmune diseases or infections can also cause SI joint pain. We call this inflammation sacroiliitis. Ankylosing spondylitis is one of the more common autoimmune diseases that is specifically associated with sacroiliitis and SI joint pain.
I would like to now introduce our special guest speaker, Dr. Rafael Jaramillo, graduate of NYU and current Pain Fellow at Rutgers University, to help discuss SI joint disease progression and their three main stages.
SI joint disease progression. There are three main stages. The first stage, known as the new onset acute or the dysfunction stage, occurs from 1 to 4 weeks. It is characterized by minor pathology causing abnormal motion and pain. There is usually some spasm of the surrounding muscles, and if you were able to visualize the SI joint itself, there would be abnormal movement. The second stage, the subacute/intermediate stage, also known as the instability phase, this occurs from 4 to 12 weeks. The SI joint stability is further disrupted, and you may start to see walking problems, potentially leading to the opposite leg or favoring the opposite leg more than the painful side. There is continued pain during this phase. The third stage, the chronic/stable, also known as the stabilization phase, occurs greater than 12 weeks or 3 months. There is evidence of bony and joint breakdown called degeneration or sclerosis, even joint erosions. Severe versions of this is called ankylosis. Because of how long this is occurring, the opposite joint may start to be affected as well.
Thank you, Dr. Raphael Jaramillo. I would like to now bring back Dr. Ashley Wong, who will discuss how patients present with SI joint pain, what physicians should look for, and what treatment options there are.
Patients with SI joint pain usually present with sharp, one-sided, or unilateral pain located in the buttocks or low back. The pain may radiate or travel to the posterior or back of the leg or groin area, and therefore can be confused with other conditions such as hip problems or herniated lumbar discs. There is usually an absence of neurologic symptoms such as numbness or tingling, and weakness in the legs with SI joint pathology. If SI pain persists, the patient may develop gait dysfunction or difficulty walking, especially after sitting for too long. Patients usually report pain or stiffness that worsens with running, lying on one side, climbing stairs, or sitting for prolonged periods. It is usually localized to one side, although sometimes it can occur bilaterally or on both sides. Physicians should focus on history taking, which includes inquiring about recent trauma, work activities, physically active hobbies, or recent pregnancy. A recent history of illness or fever may suggest an inflammatory condition of the SI joint. Physician examination should focus specifically on SI joint and pelvic area pain. Exam begins with inspection of the pelvis during standing, which may reveal pelvic obliquity or differences in pelvic height. This may be a sign of SI joint dysfunction. Physicians should also look for leg length discrepancy, which is a risk factor for SI joint pain. Palpation of the bilateral SI joints may reveal focal tenderness. Unilateral pain at or below the PSIS, without any pain above the L5 area, is highly suspicious for SI joint pathology. The patient's gait should also be observed, noting any pain with ambulation or asymmetry in stride. There are provocative tests for the SI joint, which include the Gainsland test, compression test, distraction test, thigh thrust, and Faber test, which stands for flexion, abduction, external rotation. 3 or more positive special tests indicate that the patient's pain is likely from the SI joint, with 90% sensitivity and 78% specificity. There's also a sign that can help physicians pinpoint SI pain, and that's when the patient points to about 1 centimeter inferomedial to the PSIS. This is called the Fortin finger sign. Overall, physicians and patients should understand that SI joint pain is a diagnosis of exclusion, meaning other more dangerous conditions should be ruled out. Physicians should rule out other inflammatory diseases like ankylosing spondylitis, Reiter syndrome, which is a condition typically affecting young men, characterized by arthritis, conjunctivitis, and urethritis. They should rule out psoriatic arthritis, enteropathic arthropathies, or other spondyloarthropathies. Routine examination of the lumbar spine and hip should also be done to look for other sources of pain or concomitant problems. Laboratory studies are not routinely done unless there is a suspicion for cancer or systemic disease. If these are suspected, CBC, ESR, CRP, ANA, rheumatoid factor, and HLA-B27 tests may be ordered. If cancer is suspected, PSA, calcium SPEP, UPEP, and other age-related cancer screening tests may be done. Imaging. The SI joints can be evaluated on plain AP lumbar or pelvic X-rays. Signs of arthritis may be seen in the joint with these views. A more focused view is called the Ferguson view, which may be ordered. This is a 20-degree caudocephalic AP X-ray. If sacroiliitis, nerve impingement, or spinal stenosis is suspected, CT and/or MRI may be ordered. Treatment for SI joint pain. Physicians will usually initially prescribe conservative care. This includes physical therapy, education on proper body mechanics, manual manipulation of the sacrum, and activity modification. Therapy can be focused on lower extremity muscle balance, increasing lumbar and lower extremity flexibility, lumbar stabilization, and core and gluteal strengthening. Superficial heat and medications such as NSAIDs or muscle relaxants can be used in conjunction. If there is no response to conservative therapy, a discussion with a licensed and fellowship-trained pain management physician may be necessary. A treatment that has been found to be both diagnostic and therapeutic is an intra-articular sacroiliac joint steroid injection. These injections are performed under fluoroscopic or ultrasound guidance. It may be necessary to have multiple injections. If longer-term relief is desired, another highly successful treatment may be performed. A licensed and fellowship-trained pain management physician may discuss and offer a technique called radiofrequency ablation, which allows for longer-lasting pain relief by rapidly heating or even rapidly cooling painful nerves causing pain in the SI joint. Before pursuing radiofrequency ablation, there is a requirement that the patient undergo at least 2 SI joint injections, done on 2 separate occasions, that provide adequate pain relief. Other advanced procedures can also be discussed, including lateral branch neurotomy. If conservative treatment, injections, and advanced techniques like radiofrequency ablation all fail, or pain still is not adequately controlled, a referral to a neurosurgeon may be necessary. There are somewhat newer techniques currently being developed, including minimally invasive SI joint fusion. However, that will be presented on a separate episode in the future. Other non-surgical options are also available. Emerging interventions for SI joint pain include prolotherapy and PRP injections. Prolotherapy is done by injecting an irritant solution, such as dextrose mixed with lidocaine, into the joint to help promote healing and growth of normal cells. PRP, or platelet-rich plasma, is another injection that uses a concentrate from the patient's own blood to help stimulate new growth where injected. Current literature shows promising early results. However, further studies must be done to determine long-term efficacy in comparison to current standards of care. Of note, there will be a separate episode on PRP, so please subscribe to Regen Med 101 to learn more about this new medical treatment.
SI joint pain is an underdiagnosed and undertreated pain condition. It is important to have a fellowship-trained pain physician to evaluate your pain, as these highly trained physicians offer more options to help treat these types of pain. I would like to thank Dr. Ashley Wong and Dr. Rafael Jaramillo for not only sharing their knowledge on SI joint pain, but also a previous episode on Regen Med 101, including frozen shoulder, stroke, and complex regional pain syndrome. If I could invite Dr. Ashley Wong back to close out this podcast on SI joint pain.
SI joint pain is a relatively common cause of lower back pain. Since the symptoms of SI joint pain often mimic lumbar or hip pain, it's important to always keep SI joint pathology on the differential diagnosis. Many patients will find relief simply with conservative treatment, such as physical therapy and medication management. However, if pain continues despite these treatments, interventional techniques performed by a licensed and fellowship-trained pain physician, such as intra-articular steroid injections or radiofrequency ablation, are available. Newer treatment options such as prolotherapy or PRP show promising early results and should be discussed with your physician closely. Thank you for listening to Regen Med 101. Check back in the future for my podcasts and discussions.
Knowledge is power, and it is the first step in knowing your condition, disease, or injury.
If you enjoyed listening to our podcast, please visit our Instagram, Twitter, and Facebook. For more detailed information, please visit our website at regionmed101.com.
This podcast is made for the general education to the public and is not intended to substitute for or provide medical advice. All information, content, and material from Dr. Yu and his guests on Regen Med 101 is for informational purposes only and are not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified physician. Please see podcast and page content for full disclaimer. If you have a medical emergency, call your doctor or 911 immediately.